Hi, it's Bree Smith, SN, here to help you succeed in nursing school and on the NCLEX.
These videos will be general reviews that harp on the major points you should know for these drugs, not so much the nitty-gritty details. So make sure to use this in addition to your primary academic resources. In this video, we are covering a wide variety of cardiovascular drugs, so check the chapters and timestamps to help you find specific ones you are wanting to focus on. Let's begin. This video will begin with discussing drugs that are used in the treatment of hypertension. The first class we'll explore are the ACE inhibitors, which tend to end in pril and prevent the transformation of angiotensin 1 to 2 in the RAAS pathway. ACE inhibitors decrease the amount of water and sodium in the body, reducing blood pressure as a consequence. Potassium, however, is spared, and we will expand upon that concept in a moment. Captopril is indicated for the treatment of hypertension, so reduction in blood pressure is expected, especially upon first dose. However, be aware that marked hypotension should be monitored for. Observe fall precautions as needed for these patients, and provide instructions for slow positional changes in patient teaching. ACE inhibitors are potassium-sparing, placing the patient at potential risk for hyperkalemia that can lead to fatal cardiac dysrhythmias. Be sure to monitor sodium and potassium levels for the patients, and advise dietary changes as indicated. The patient should avoid salt and salt substitutes, as these substitutes are often high in potassium. A persistent dry cough may indicate that the patient should no longer take this medication, as it indicates that increased bradykinin in the body increases risk for a severe hypersensitivity reaction. The nurse's priority is to assess the patient for angioedema and restore the patient's airway, as well as provide IV epinephrine. To reiterate, with these drugs, pay attention to the ABCs. Compromised airway due to angioedema and severe hypotension due to first dose effects are priorities to look for. Hyperkalemia and hyponatremia are important to monitor for over time. In a similar vein, now is the angiotensin receptor blockers, or ARBs. Our prototype here is losartan. Like the ACE inhibitors, sodium and water is excreted while potassium is spared. Perfusion to the kidney is also increased, likewise indicating this medication in the treatment of nephropathies to promote renal functioning. The considerations and side effects of this medication are very similar to our ACE inhibitors. If the patient has an angioedema reaction to ACE inhibitors, they may also be contraindicated from using ARBs as well. Nifedipine is a calcium channel blocker, therefore decreasing contractility and promoting vasodilation in the arterioles. Please note that other calcium channel blockers we will explore later on act on both the arterioles and the heart. As vasodilation occurs and blood pressure is reduced, reflex tachycardia may occur as a compensatory mechanism to maintain cardiac output. This tachycardia may also be accompanied by tachypnea. These together may indicate the inclusion of other medications such as beta blockers, which can reduce heart rate. This indirect impact on the heart can lead to ischemia or infarct for patients with acute coronary conditions, so administration is contraindicated in these patients. Doxazosin is used in the treatment of hypertension and BPH due to the vasodilatory impact it has on the vessels. Like the previous drug, vasodilation and hypotension can lead to reflex tachycardia. Ensure the patient taking this medication is not combining its use with other vasodilatory drugs, such as sildenafil, or else severe hypotension may result. On to beta blockers, which you can recognize due to the LOL at the end of their generic names. These drugs reduce cardiac excitation and workload, reducing both heart rate and blood pressure. While these outcomes can be therapeutic for some patients, the medication may have certain parameters set for the patient that require it to be held, such as if the heart rate is less than 60 beats per minute. Beta blockers can exacerbate severe heart failure since cardiac output is already compromised, and can also exacerbate chronic respiratory conditions such as asthma, as these medications can cause bronchospasm. Avoid administering beta blockers to these patients. Clonidine is also used to increase cardiac output by reducing heart rate and promoting vasodilation that lowers blood pressure. This medication is centrally acting and has been found to have other uses, such as in the off-label treatment of drug and alcohol withdrawal, ADHD, hot flashes, and Tourette syndrome. If the patient is discontinuing this drug, the process should involve tapering over time. A sudden discontinuation can lead to severe rebound hypertension to manifest. Our final drug we'll discuss indicated for the treatment of hypertension is the direct-acting vasodilator hydralazine, which functions to vasodilate the arterioles and decrease arterial blood pressure, likewise causing increased heart rate. Vasodilation is occurring, but this medication is not a diuretic, so the patient may experience edema as fluids shift between compartments in the body. On to drugs drugs utilized in the treatment of heart failure, first starting with diuretics that act to reduce the workload of the heart, and then moving on to some medications that more directly impact the heart itself. Our first diuretic is hydrochlorothiazide, a diuretic that is potassium wasting, meaning that in addition to water and sodium loss, potassium is also excreted. Patient teaching should emphasize monitoring for indications of hypokalemia, such as muscle weakness and cramping. With all of our diuretics, a potential complication is relative hyperglycemia, as serum glucose levels become more concentrated, in lieu of other serum contents being lost through diuresis. Furosemide is another diuretic. This loop diuretic commonly seen in the treatment of heart failure, edema, and hypertension. Like hydrochlorothiazide, it is important to monitor for hypokalemia with this medication. Ototoxicity is also a potential complication, and so administration concurrently with other ototoxic medications, such as aspirin and various antibiotics, should be avoided. Patient education should include reporting tinnitus, a ringing in the ears. Our last diuretic here is spironolactone. This medication, being unique to the other two, is a potassium-sparing diuretic. Potassium is not excreted as a consequence of administration, and so patients should be sure to avoid excessive intake of potassium in their diet. Combined use with ACE inhibitors can lead to hyperkalemia, placing the patient at even greater risk of complications. A fun fact about this medication is that it has an off-label use in the treatment of acne. Now on to digoxin, a medication that is highly favored by NCLEX prep, so make sure to keep this med in mind. Digoxin slows and strengthens the heart. Think of digging for a deep contraction. With that, our patient is expected to have a lower heart rate. Prior to administration, the nurse should measure the heart rate at the apical site for a full minute. If the heart rate is below 60 beats per minute, the drug may need to be held, as exacerbating bradycardia could compromise the patient's cardiac output. Digoxin toxicity is a major concern, as this med has a narrow therapeutic range of 0.5 to 2 nanograms per milliliter. Early signs of toxicity manifest as GI distress, progressing to visual changes such as blurred and yellow halo-tinted vision, and then on to CNS changes such as confusion and delirium. The antidote for digoxin toxicity is Digibind. Sympathomimetics are medications that increase the rate and force of the heart, also encouraging greater renal perfusion, making these drugs useful in the treatment of shock. Our prototypes dobutamine and dopamine are highly vesicant medications and should only be administered via central or PICC line. These medications will be titrated for effect, and the patient receiving these medications should be under frequent assessments per facility protocol. By increasing the rate and force of the heart, we may send the patient into dangerous tachydysrhythmias, and so the nurse should anticipate continuous ECG monitoring. PDE5 inhibitors, such as milrinone and sildenafil, are also used to treat heart failure by decreasing workload on the heart by causing vasodilation. These medications are indicated for short-term treatment of low cardiac output, as well as for the treatment of pulmonary hypertension. Vasodilation can cause the patient to become hypotensive, and so patient education should emphasize slow positional changes and avoiding combining these drugs with other vasodilatory medications. Now onto drugs which are used in the treatment of coronary artery diseases, including lipid-lowering agents as well as potent vasodilators. Atorvastatin is a lipid-lowering agent used in the treatment of high cholesterol and to reduce the complications of coronary artery disease. There are some major teaching points with this medication that we should emphasize. Statins are linked to potential complications such as myopathies, and so the patient should be assessed for muscle pains and rhabdomyolysis. These drugs can also be very hepatotoxic, and so liver function tests should be monitored for these patients. They should be assessed for presentations of liver complications, such as jaundice, anorexia, and ascites. Patients should be advised to not combine with anticoagulant or antiplatelet medications such as warfarin and aspirin, as doing so can increase the risk for bleeding. The patient should also be instructed to take this medication at night to be most effective, as the majority of cholesterol synthesis within the liver occurs within the nocturnal period. Gemfibrozil is another lipid-lowering agent, which has similar indications as the aforementioned statin. Complications are also similar. However, gemfibrozil may also cause adverse effects for the gallbladder. Impaired gallbladder function may lead to patients becoming intolerant to fatty foods, as well as increased risk for gallstones. Finally, we have our nitrates, nitroglycerin and isosorbide. These medications are indicated for the treatment of angina, as by causing vasodilation, perfusion is improved in the areas of ischemia. Since vasodilation is occurring, monitor the patients for hypotension hypotension and reflex tachycardia. While some side effects, such as headache, are expected due to the increased vasodilation, monitor for risk of falls, as well as worsening cardiac output. Beta blockers may be indicated if reflex tachycardia is not tolerated by the patient. To reduce risk for excessive hypotension, avoid concurrent use with other vasodilators, such as sildenafil. Before we move on from this section, let's quickly review some ways patients may take nitroglycerin and the proper forms of administration. Sublingual tablets should be allowed to dissolve under the patient's tongue. If pain is unrelieved after the first dose, the patient should seek out emergency services due to the potential of a myocardial infarction occurring. The patient can take up to 3 sublingual tablets, with a period of 5 minutes between each dose. A transdermal patch can provide continuous symptom management for patients with stable angina. Patches should be applied to a clean, hairless site and kept on for 10 to 12 hours and then removed for an equal amount of time. Sites should be rotated to avoid skin irritation. Patches are used to prevent anginal pain and should be applied as prophylaxis rather than as a response to onset of acute anginal pain. Last is the topical ointment form. The dose will need to be carefully measured out and then covered with plastic wrap once applied to clean, dry skin. The nurse should make sure to wear gloves throughout the application process to avoid accidental exposure to this medication and its potent side effects. We'll now review medications that are used in treating cardiac dysrhythmias. We'll start with sodium channel blockers, those being procainamide, lidocaine, and flecainide, to name some prototypes. Now, with these sodium channel blockers, you can go into much more depth with their specific mechanisms of action, but for our purposes, we'll keep things pretty general and focus on the more high-yield content. These drugs slow the rate of depolarization by impacting sodium channels, meaning that we should monitor the patient's electrolytes and cardiac status throughout the duration of therapy. To impact the heart most effectively, these medications should be given IV. For long-term control of conditions such as AFib, patients may be given PO forms. If you'll recall, lidocaine can also be used as a local anesthetic, such as with EMLA creams. In this instance, since we are giving the medication IV, the heart's conduction system is impacted, thereby producing the therapeutic effects we are seeking with this drug. Now for the non-selective beta blocker, propranolol. Remember, we can recognize our beta blockers due to their common ending of LOL. Beta blockers slow the heart down, making them effective in treating tachydysrhythmias. But since this is a non-selective beta blocker, bronchospasm may occur as an adverse reaction. And so those with chronic respiratory conditions such as asthma are contraindicated from using these meds. Patients with diabetes mellitus should be aware that they will have to rely on other physiological cues to alert them to hypoglycemia if they are on beta blocker medications, as the slower heart rate produced by these medications can mask the tachycardia that characterizes low blood sugar. Patients should be advised to discontinue these medications slowly and with provider supervision, as rebound hypertension and tachycardia can occur upon sudden discontinuation. Now, the potassium channel blocker, amiodarone. This medication is one you may see in codes, as it can be effective in treating ventricular tachycardia or ventricular fibrillation. However, adverse effects of this potent drug can be severe, including pulmonary toxicity and fibrosis. More commonly seen adverse effects include bradycardia, GI distress, photosensitivity, and the very strange and unique blue-gray skin discoloration upon exposure to UV light. Verapamil and diltiazem are calcium channel blockers. Think back earlier to the hypertension medications we focused on. We mentioned another calcium channel blocker, nifedipine, but that drug is not present here because while nifedipine's effects are limited to the arterioles, verapamil and diltiazem impact the arterioles and the heart. These meds slow the rate of the heart, meaning we can expect a slowed heart rate as a therapeutic effect. Of course, since the arterioles are also dilated, we want to be sure to monitor for hypotension with these patients as well. Avoid concurrent administration with antihypertensives or vasodilatory medications, as this can lead to severe hypotension. Of note, calcium channel blockers are contraindicated for use with patients diagnosed with Wolff-Parkinson-White syndrome, as the abnormal electrical conduction system for these patients can be fatally impacted if these meds are administered. Thank you for watching this quick review of cardiovascular drugs. While this is far from a comprehensive breakdown, the most commonly emphasized points on the NCLEX and in clinical practice are covered here. Please make sure to utilize your assigned textbooks and modules in addition to this review.
Remember to keep studying and keep working hard.